case we're presenting this
This
evening
meeting
is
is
a
being recorded.
7-year-old right-handed trader that resides in Warri, Delta State. She's Igbo of Pentecostal denomination. She presented to us with progressive right-sided hearing loss of 1.5 years duration and unsteady gait of 6 months duration. Patient was stable until 2 years prior to presentation when she noticed a gradual reduction in hearing in the right ear, which was insidious in onset and slowly progressive, and I said earlier, located to the right side. Initially, patients could hear conversations in noisy environment, but the hearing loss progressively deteriorated. Eventually, that patient could not even hear from the right ear, even in the quiet environment. There was altered tinnitus, no ear discharge, no pain. About 6 months before she presented to us, she developed progressive unsteadiness while walking, which was gradual, and she also had difficulty in maintaining balance, especially while walking and waving, tend to veer towards the right side. So she had occasional vertigo, no loss of consciousness, no limb weakness. Gait abnormality progressively worsened, such that patient can barely walk, except without falling, except being assisted by the relatives. No facial numbness, no weakness of any facial muscle. There was isolated occasional headaches, which was dull and located in the occipital region. No blood, no visual complaints. No history of trauma, no exposure to explosive medication, no recurrent ear infection, no previous history of tumors in this patient nor in the family. No previous intracranial surgery, no comorbidities. Patient does not drink alcohol nor use tobacco in any form. No occasional exposure to noise. In summary, I presented a 47-year-old woman that presented us with a 2-year history of progressive hearing loss on the right side with tinnitus, followed by 6 months of progressive gait instability and pause. There are no features of middle ear disease, illness. On examination, we found a lady, a young middle-aged woman, alert and well-oriented, not any obvious distress, no cutaneous marker of neurofibromatosis type 2. GCS was 15, pupils were equal and brisk, no signs of meningeal irritation. The 8th cranial nerve on the right showed that the Ryan's test was positive bilaterally. Weber's test was lateralized to the normal ear. Whisper's test was reduced on the right side, and she had unsteady stance. Other cranial nerves that were examined, she had weakness on the right side of the face, Haussmann Brachman 2 on the right side. Other cranial nerves were essentially satisfactory. This is the contrast image corner.
I think I can't see your presentation anymore. Can everybody else see it?
No, it's off, sir.
Okay, sorry, we are trying to have, let me reconnect, sorry.
Sorry, sir. We are trying to reconnect. We have issues with network. It's raining heavily here. Sorry about that, sir.
Welcome. Hey, today was your clinic, what? Okay. It's great. Oh.
Hello, Dr. Edwards. What are the problems?
So we're having problems sharing from our laptop, sir.
For if you go through the pathway you went before, what's the
Yes.
problem by doing that?
Just stop,
We initially,
stop sharing and reshare.
but yes, sir.
Stop sharing and then reshare.
Okay, sir. Try that, sir.
Any success? Dr. David, any success?
Yes, sir.
Sincere apologies for the break in transmission. So this is the contrast image cranial axial MRI of the patient that I presented earlier, that showed a right mass lesion originating from the right the petromastoid bone, reaching through the porous acousticus and just aborting around the brainstem of the patient. So we made an assessment of a vestibular schwannoma for this patient, for which we counted both the patient and relatives on diagnosis and proposed surgical intervention with its aims, goals, benefits, and possible risk from the surgery. So we are presently working out for surgery in a few days' time. Sincere apologies that we could not get the information of the patients that we've operated. Few of them that we've operated, we tried to get their information, but we could not lay hands on their record. So, but we have this one that we are yet to operate. So that's why we are presenting this one. Vestibular schwannoma occurs with 1 to 2 per 100,000 a year, and it occurs between the 5th and 6th decades of life, rare in children except with those with neurofibromatosis type 2. It does not have any predilection for sex. It most times occur unilaterally, that's about 95%. And if bilateral, the diagnosis of NF type 2 is made. But it accounts for about 8% of all intracranial tumors, most of which it accounts for most of the CPA tumors, that's between 80 to 90% of them. Vestibular schwannoma it has been attributed to some genetic mutation, like the Merlin gene or the Schwannomin gene. It's actually a tumor suppressor. It's not a tumor suppressor gene, so that when mutated, the growth of prevention of Schwann cells are not under check. So tumor occurs and continues sporadically and continue uncontrolled rather. Why the second cause in terms of etiology is sporadic, which accounts for about 95% of unilateral vestibular schwannomas, typically non-hereditary and develop later in life. Syndromes that are still with vestibular schwannoma, we have the NF type 2, which is an autosomal dominant disorder characterized by bilateral vestibular schwannoma, and or we can also have multiple intracranial tumors. We have schwannomatosis. It's also a syndrome that's also out with vestibular, whereby you have multiple schwannomas occurring. But of note is that the vestibular nerve is spared in patients with schwannomatosis, for which the possible etiology is actually the mutation of the SMARCB1 gene, which is also a tumor suppressor gene also. Environmental factors such as exposure to radiation is also a risk factor. It's the strongest non-genetic risk factor, especially when an individual has been exposed to radiation in early childhood. Although there's use of mobile phone, although a weak and inconsistent evidence that it can be a cause of vestibular schwannoma. The temporal bone is located within the skull base, consisting of its petrous, tympanic, and mastoid portions. For the purpose of this discussion, we will come down on the petrous part of the temporal bone, which is the densest and the most complex portion of the skull bone, houses critical neurovascular and sensory structures. This image shows both the surface and the internal boundaries of the temporal bone, where it articulates with the parietal the frontal, zygomatic, and occipital bone. The squamous part is actually the largest part of the bone that also contributes, gives which also contributes to the zygomatic process. The inner part of this temporal bone is actually pyramidal shaped, tailing down anteromedially towards the middle cranial fossa. This image also shows us the portion of the petrous mass, the portion of the petrous temporal bone that contains the internal acoustic canal that houses the cranial nerve 7 and cranial nerve 8. This image, as you can see, shows us the exit, that is the porous acousticus. The anatomy here is important. The knowledge of the anatomy here is very important, especially during surgery, during surgery, because the porous acousticus is divided into an upper and lower part by the crista falciformis. So this upper part accompanies the facial nerve and the superior vestibular nerve. This upper part is further again divided into two by a vertical ridge known as the B's bar that separates the facial nerve from the superior vestibular nerve. While the lower part of this porous acousticus actually contains the inferior vestibular nerve and the cochlear nerve. I've actually talked about this once before. However, in discussing vestibular schwannoma, because of its extension most times into the cerebellopontine angle, it is also important to look at brief anatomy of the cerebellopontine angle, which is actually a CSF feed subarachnoid space located between the pons. Pons bound it medially, laterally by the petrous temporal bone, superiorly by the tentorium, and posteriorly by the cerebellum. It actually contains the 5th, 7th, and 8th cranial nerve, and it actually houses vessels like the anterior and inferior cerebellar artery, the petrosal vein, and the cerebellopontine system. The CPA actually acts as a transition zone where cranial nerve exits the brainstem and where cranial nerve actually exits the brainstem. Vestibular schwannoma usually arises from the internal acoustic canal and extends into the CPA angle as the pathology progresses to compress the brainstem and possibly the cerebellum. This table below shows us the affectation of the various cranial nerve and cerebellum and brainstem depending on the size of the mass. If the tumor is just intracranicular alone, we have the cranial nerve 8 that has been involved. So as the tumor keeps expanding and exiting through the porous acousticus, further structures like the cranial nerve 7, 5, cerebellum, and brainstem can now be affected. In classifying vestibular schwannomas, the Kuhn's classification, which is most widely used, is what is being projected here. It grades the tumor into grade 1 to 4. 1 as intracranicular, 2 as extended. Grade 3, it actually fills the cerebellopontine angle but touches the brainstem, but no brainstem compression. But when we get to grade 4, we now have brainstem compression. The SAMIS classification actually classified it also into 4, but now have subdivisions at 3, and at stage 4. At stage 1 is purely intracranicular. Stage 2 does extend into the CPA angle for less than 2 cm. Stage 3A means that it has filled the CPA but no contact with the brainstem. 3B has touched the brainstem but no compression. 4, there's compression. And 4B means that there's severe compression with displacement of the brainstem to the contralateral side. Now, the house classification further classified this tumor in terms of size, and also classify the tumor based on the ability to carry out a hearing sparing surgery for the patient. It classified tumor as small, medium, large, and giant, as you can see in the screen, on our screen rather, where we have a small tumor less than 1.5 cm, medium 1.5 to 3, large greater than 3, and giant tumors greater than 4. But the description also coincides with the previous classification done by Poole and Sami. House further now added pure tone odometry and speech discrimination score. This is aimed at determining possibility of a hearing sparing surgery, which aids counseling of the patient for possible outcome that we all should expect. And also, we also guide the surgeon during surgery to determine the approach and carefulness during surgery. So the house classified the hearing of the patient to class A as it classifies the tumor as small and patient having excellent and good hearing. That's class A and class B. It means that patient hearing status is good and hearing preservation surgery is possible. When we have medium-sized tumor between 1.5 to 3, we have with class A, that's excellent or good hearing. It's actually a selective case, so we can attempt hearing preservation surgery. But with large tumors and with patients with class C and class D with poor hearing, trans-labyrinthine approach is often preferred. Other classification system, now talk about the radiological classification based on MRI, talks about the size and the brainstem affectation. Then anatomical classification, talking about the intracranial CPA involvement, then combined internal acoustic canal and CPA, then the internal labyrinthine schwannomas, which is actually rare. That's for the anatomical classification. Usually, vestibular schwannoma actually arise close to the root entry zone. That is also known as the Obstina-Redlich zone, which is actually near the porus acousticus. 90% of vestibular schwannoma actually affects the inferior vestibular nerve. The inferior vestibular nerve is preferentially affected because it has a longer intracranial course than the superior vestibular nerve. So there is more Schwann cell proliferation with the inferior vestibular nerve. So this predisposes it to have more of vestibular schwannoma. And they can also occupy the cerebrofontanine angle as earlier discussed. And this canal is supplied by the internal auditory artery. Schwannomas generally are firm. They are rubbery, gray-white with yellowish area, an occasional focal area of hemorrhage and cyst formation, depending on the size of the lesion. They are generally well circumscribed and encapsulated, and represent masses. They are WHO grade 1 tumors consisting of spindle cells with wavy or buckled nuclei, arranged in distinct patterns referred to as atony A and atony B. The atony A group they have dense compact eosinophilic spindle cells arranged in intersecting fascicles, while the atony B are arranged loosely with multipolar processes spread apart by prominent mesoid extracellular masses. Verrucate bodies are also seen as alternating arrangement of palisading nuclei and cell bodies from the atony A tissue. This is a photomicrograph from a schwannoma, that is showing the attorney A as labeled attorney B and the verocave bodies. Dr. David Edet will continue from here.
Thank you, Dr. David, for the presentation. We now call on Dr. Awoyemi for the second part of the presentation. Questions and answers will follow after the presentation. Thank you very much.
Okay, thank you, sir. The first presentation was actually made by Dr. Awoyemi. It's using my device. Okay, so I am Dr. David Daniel Edet. I'll be taking the evaluation and management of vestibular schwannomas. So objectives of evaluation generally to confirm. Hello. Can I be heard, please?
Your screen is gone again. We can't see your presentation.
Sorry about that. Sorry about that, sir. Let's try to be connected, please.
Dr. David, what is happening, please?
Sorry, sir. Our laptop is connected. So we're trying to connect. We have issues with network, sir. Sincere apologies for the frequent interruption in the presentation. We are having issues with our network. So, Dr. David, I'll be taking the evaluation and management of vestibular schwannomas. So the objective of evaluation of
Remember, you have 25 minutes for the presentation.
Yes, sir. Thank you, sir. Basically, to confirm the diagnosis, stage, and determine the tumor size, and then growth characteristics of this tumor. And also to evaluate the auditory and vestibular functions of the patients. Also to prognosticate and determine fitness for intervention where necessary. So the evaluation entails clinical evaluation, radiologic, test of auditory and vestibular functions, and laboratory workup. So in the history, the history of age is important because vestibular schwannoma is common in people aged 50 to 60 years. However, in people with neurofibromatosis, it can occur present in patients younger than 30. Traditionally, sex is not considered, or a vestibular schwannoma is not considered to, or is not known to have gender predilection, but there are some studies that have suggested that it is actually more common in male patients over the age of 70. The classic triad of vestibular schwannoma includes unilateral sensory neural hearing loss, tinnitus, and disequilibrium or classical vertigo. Other symptoms can include features of cranial nerve dysfunction, as well as brainstem features, including ataxia, hemiparesis, also hydrocephalus, especially for tumors that are greater than 2 cm. Risk factors should also be considered, particularly in patients that have family history of neurofibromatosis type 2 and patients that have previous radiation history. Comorbidities should also be considered, as this can determine the treatment modality for this patient. So this basically shows the diagnosis grading system for neuromas and business grading system, grading from grade 1 to grade 4, grade 1 being absence of symptoms with diagnosis or dizziness, and grade 4 representing persistent symptoms that may interfere or that interferes with work and sleep. So during examination, generally, most patients are conscious. However, when there is rest intracranial pressure, when patients have hydrocephalus, there may be alteration of conscious level. Nystagmus may be present, which may be central or peripheral. Central, particularly when it's intrameatal, when it has extended to involve the brainstem, patients may have central nystagmus. Peripheral, when it is purely within the canal, but if it extends to involve the brainstem, patients may have central nystagmus. Patients may also have impaired corneal reflex as a result of either trigeminal nerve dysfunction, which subserves the sensory arm of the corneal reflex, or the facial nerve dysfunction, which subserves the motor arm of the reflex. Ophthalmoplegia may be present, especially in patients that have raised ICP, that they have abducent nerve palsy. Visual impairments may be a reflection of raised ICP with subsequent development of papillary edema. It may also be a result of compression of the PC against the tentorium as a result of the sheer mass of the tumor. Facial nerve dysfunction may present with facial weakness, addusia, as a result of disruption of the special visceral afferent fibers of the facial nerve, as well as its Beja sign, which refers to hypoesthesia along the posterior wall of the external acoustic meatus, which is observed by the facial nerve. Vestibulocochlear nerve dysfunction may be indicated by a positive Ryan and a Weber that lateralizes to the normal ear. This is when hearing impairment is not so bad in this patient, but when the patient has profound deafness, Ryan's test may actually be negative because the sound of the tuning fork is conducted along the bone and is heard by the positive Ontebega's test significant dysfunction. And this refers to tendency of the patient who is matching with the upper extremity stretched at 90 degrees. This patient tends to fall to the side of the lesion. Other cranial dysfunction can be present, and contralateral hemiparesis and Bardinsky sign can be present when there is brainstem involvement. It is worthy of note that 66% of patients, however, may have no abnormal physical finding except for hearing loss. This picture just shows the grading out and back of the facial nerve function. Most patients do not develop facial function anyway, depending on the size of the tumor. However, when this is present, it is important to grade this facial nerve using the House and Bragman scale. So this serves as a baseline for subsequent comparison of post-operative facial nerve status. Radiologic evaluation aims at identifying and characterizing tumor, determining the size and volume of the tumor, determine the relationship with adjacent neurovascular structures, the presence or absence of hydrocephalus, and to evaluate the bony anatomy for subsequent or for patients that are to undergo surgery. The modalities include MRI and CT scan. While MRI is the gold standard because it has high sensitivity, about 98% sensitivity with almost 0% false positive rate. These patients should be evaluated with several sequences, and the sequences include the thin cut T1 MRI with and without gadolinium contrast. Also T2 images, heavily T2 weighted images like the Fiesta sequences, as well as the diffusion weighted images, which is important for exclusion of important differentials like epidermoid cyst. So CT scan helps to show bony anatomy. However, in conditions where MRI is contraindicated, like patients who are claustrophobic or patients who have MRI non-compliant or non-compatible implants, or patients for which there is concern of gadolinium-induced toxicity, CT scan can be used and can be very useful. So this next slide shows cranial MRI images. On the left, we have the T1 weighted image showing the a right-sided cerebellopontine angle tumor that is hypointense to the brain, so adjacent brain parenchyma. It shows its extension. It's extending from the region of the internal auditory hiatus and impinging on the brainstem. Now, in the middle, in the top middle column, we have the T1 contrast enhanced image that shows homogeneous contrast enhancement of this lesion, which is an important characteristic of these vestibular schwannomas. On the top right corner, we see the Fiesta image that shows the distinct contrast between the lesion and the brainstem. Beneath that is the T2 standard fast spin echo T2 for comparison, which actually buttresses the fact that Fiesta images are important in evaluation of this patient because they help to show the tumor in relation, or the relation of the tumor with surrounding structures like the brainstem, other nerves, and also in the cerebellopontine angle system. This next slide shows the cranial CT, axial cranial CT scan images. On the left is the non-contrast CT image, shows the tumor as a hypodense lesion. In the middle slide, we have the contrast enhanced CT scan, which shows contrast enhancement. And on the right, we have the bone window that shows enlargement of the internal acoustic meatus, a sign that is referred to as the truncated internal auditory meatus sign. The temporal bone CT scan is also important in surgical planning. For instance, in middle fossa approach, the bony coverage of the genicular ganglion is evaluated to identify the dehiscence. For translabyrinthine approach, extent of pneumatization of the mastoid and position of the sigmoid sinus can be evaluated, as well as the position of the jugular bulb. A high riding jugular bulb, as well as a poorly pneumatized mastoid sinus and an anteriorly placed sigmoid sinus, that's a tight space and maybe contraindication for this approach. For retrosigmoid transmeatal approach, location and thickness of bone coverage over the posterior sacral canal and vestibular aqueduct can be assessed. This allows the surgeon to know the thickness of bone to drill to prevent entering into the semicircular canal and subsequent hearing impairment and CSF leaks. The extent of peritubular air cells and retrofacial air cells can also be assessed in planning the approach. Auditory function assessment includes pure tone audiometry, which assesses the functionality of hearing. This helps in treatment decision making and also acts as a baseline for further comparison. Speech discrimination test is particularly useful in determining serviceability of hearing and for prognostication for patients that are intended to have hearing preservation surgery. So in vestibular schwannomas, they typically cause a retrocochlear sensorineural hearing loss. And this shows in audiologic examination as disproportionately what wasn't speech discrimination as opposed to pure tone average. Now, this next slide shows Gardner and Robertson modified hearing classification, which uses pure tone audiogram and speech discrimination to classify patients into those having serviceable hearing and those with non-serviceable hearing. This is another slide that shows another type of classification by American Academy of Otolaryngology Head and Neck Surgery Foundation. So serviceable hearing is defined as AAO HNS class A or B and Gardner-Robinson classes 1 and 2. However, of recent, there is a tendency for more stringent classification, and some authors and some neurosurgeons have actually shifted to the 70-30 rule, which says that the serviceable hearing refers to speech discrimination score of greater than 70% and pure tone average of less than 30 decibels. So definition may also be modified based on the hearing status of the contralateral ear. For instance, if the contralateral ear has normal hearing, then a score of less than 75, a speech discrimination score of less than 75% is not considered as good hearing. However, if the contralateral ear is profoundly deaf, is completely deaf, then a speech discrimination score of 50% and above in the affected ear can be considered as good hearing. So additional tests that can be done, particularly for smaller tumors, include electronystagmography, vestibular evoked myogenic potentials to assess the vestibular nerves, and then the auditory brainstem response to which prognosticates the chance of hearing preservation. Hello. Okay, so ABR, when we have poor wave morphology in ABR, correlates with low chance of preserving hearing, even when the patient has good hearing. Workup for these patients include electrolyte urea and creatinine analysis, fasting blood sugar, full blood count, clotting profile, and cosmetic. These patients are usually elderly, so they need chest X-ray, ECG, and echocardiography. Echocardiography is particularly important for patients who are to undergo sitting surgery using the sitting or the semi-sitting position because of the risk of paradoxical arterial air embolism. So finally, informed consent, which should be taken prior to any intervention. Differential diagnosis of these patients include meningiomas, which are the second most common CP angle tumors, epidemosis, the third most common CP angle lesions, arachnoid cysts, schwannomas of other cranial nerves, metastasis, and multiple sclerosis. This slide shows T1 contrast enhanced MRI axial image of the patient with CP angle meningioma on the left and the patient with vestibular schwannoma on the right. Now we can see that the meningioma is broad-based. It has a broad-based relationship with the posterior surface of the petrous, and actually has like an obtuse angle between that posterior surface of the petrous and the tumor. Also, it doesn't extend into the internal acoustic meatus, and there is no enlargement of the internal auditory meatus. On the right, we can see the classical ice cream cone sign, which is suggestive of the vestibular schwannoma, and the fact that the tumor actually arises from area of the internal auditory meatus. Both lesions enhance. However, the meningioma, which likely the meningocellular meningioma, enhances more avidly and more homogeneously. Management of these patients, objectives include improvement of the quality of life, lower mortality and morbidity, tumor control and preservation of neurological function. It entails the use of deployment of a multidisciplinary team, which includes neurosurgeons, ENT surgeons, radiation oncologists, neuroradiologists, neuropathologists, molecular pathologists, molecular geneticists, and anesthetists. The current treatment options include observation, surgical resection, and radiotherapy. And except for bevacizumab, which is used in neurofibromatosis type 2, there's currently no role for pharmacotherapy. This is according to the European Association of Neuro-Oncology Guidelines of 2020 on diagnosis, treatment, and follow-up of vestibular schwannoma. The choice of treatment depends on the clinical presentation, tumor size, good characteristics of the tumor, and expertise of the treating center. A simple management algorithm can be considered as follows. This for small tumors that are less than 15 millimeter with normal hearing, observation can be done. Now, small tumors with serviceable hearing, the management is actually controversial, as either the serviceability of hearing can be presented either with observation, stereotactic radiosurgery, or with microsurgery. For medium-sized tumors, measuring 15 to 25 millimeter, treatment should be done either with stereotactic radiosurgery or microsurgery. For elderly and frail patients, observation may be an option. And in patients with neurofibromatosis type 2, because of the increased morbidity from microsurgery, the bevacizumab can actually be employed at this stage. Large tumors greater than 25 millimeters should be treated urgently, and microsurgery is preferred, especially for patients who have features of brainstem compression and hydrocephalus. Stereotactic radiosurgery can be employed for patients with significant comorbidities, and staged microsurgery can be done for patients with very large tumors, in which the tumor is first debulked by microsurgical techniques, and tumor debulking, and then the compression is done, followed by stereotactic radiotherapy. Observation of vestibular schwannoma should be done with a patient with small intrameatal tumors with no symptoms who are identified following scanning for other pathologies. So for these patients should undergo serial MRI scanning and audiological monitoring. The MRI should be done every 6 months for the first 2 years, and then every year. If the patient remains stable after the 2 years, then yearly for the next 5 years. So if the patient still remains stable after 5 years, then it can be done at 7, 9, and 14. Can be done at 7, 9, and 14 years. Now, the MRI should be T1 weighted, MRI T1 contrast enhanced MRI. However, for patients where there's concern of gadolinium induced toxicity, Fiesta images or sequences can be used. Now, compliance of patient has to be taken into account, since non-compliance could lead to a failure of follow-up. So these patients should be carefully selected. Radiotherapy has a goal of achieving tumor growth control. It can be performed either as stereotactic radiosurgery or fractionated stereotactic radiotherapy. Stereotactic radiosurgery, the high dose of radiation is administered at once. The dose usually has been reduced to about 12 to 14 gray. Administered at once using a conformal dose plan, usually with multiple ISO centers. So it's advantageous because it allows early control of the tumor, and treatment can be completed in one session. For fractionated stereotactic radiotherapy, which can be used for slightly larger tumors, this radiation dose is divided into fractions, which is completed over 3 to 5 sessions. Tumor control with radiotherapy is estimated at 93 to 98%. In 27% of cases, tumor enlargement can actually be observed. Radiotherapy actually appears to be better at preserving hearing than microsurgery, especially for large tumors.
Dr. David, you have about 4 minutes more.
Okay, sir. So management, limitations of management of radiotherapy includes the fact that results cannot be precisely predicted as the initially may have paradoxical growth of tumor before a subsequent regression. There will be obliteration of dissection planes and a reduction in the likelihood of functional preservation of involved nerves, and it requires long-term follow-up. In patients with neurofibromatosis type 2, caution must be applied as there is a small but potential risk of malignant transformation. Microsurgery remains the mainstay of treatment, and the complete surgical extirpation of the tumor is the only management option that leads to a definitive cure of this patient. So preservation of anatomical integrity of facial nerve is a rule during surgery. Indications for surgery are showed, including large tumors, tumors that significant tumor growth greater than 2 millimeters per year during observation, and hearing loss attributed to tumor during observation. Also, symptoms of mass effect and failed radiotherapy treatment. The goals of surgery include complete tumor resection, reduction of postoperative morbidity, improvement of preoperative audiologic and neurologic impairments, and alleviation of mass effect and hydrocephalus. These factors listed here affect surgical decision making. The tumor size, location, growth rate, and presence of cysts determines whether surgery should be carried out and the type of surgery and the approaches that should be used. Hearing status also is important, as patients with serviceable hearing should actually have hearing preservation surgeries using approaches that preserve that achieves that. Patient age and health should also be taken into consideration, and presence or absence of neurofibromatosis type 2. Important cooperative decisions and preparations include the decision of which position to take or to use, which approach to use, which side, in the case of bilateral Schwannoma, and the deployment of electrophysiological monitoring, serial and central venous catheters. Surgical approaches divided with posterior approaches and lateral. Posterior approach is a retrosigmoid suboccipital approach. Lateral approaches include the subtemporal approaches, which are the middle cranial fossa approaches, and the transmastoid approaches, which include the presigmoid, labyrinthine, and translabyrinthine and transcochlear approaches. So, retrosigmoid approach is this approach that is most familiar to most neurosurgeons, like the workhorse of CP angles surgery. So it offers quick access to tumor with less bone work, and there's possibility of hearing preservation with small or medium-sized tumor. It offers panoramic view of the petroclival region, but the cons or the limitations or cons the fact that with that we need to retract the cerebellum, the cerebellar retraction, and also we need to cut through muscles with this risk of postoperative headache. The procedure, anesthesia usually general anesthesia with endotracheal intubation. When neurophysiologic monitoring is employed after induction, the use of neuromuscular blockade is usually avoided. Lumbar drain is optional, which helps to keep the brain lax for optimal dissection, optimal and easy dissection. Central venous line also be employed. In sitting position, the central venous line may be set such that the tip is in the right atrium, which will allow for possibility of aspiration of air from the right atrium if there is venous air embolism. Neurophysiologic monitoring includes somatosensory evoked potentials, and facial nerve electromyography, as well as auditory brainstem responses. Neuronavigation can be useful in planning the incision as also in tumor section. Precordial Doppler is important, especially in these patients, especially in the semi-sitting position, because to help in detecting venous air embolism, if it occurs. Also, end-tidal CO2 can also do the same, but usually tends to show results when there is hemodynamic changes. This is the setup for retrosigmoid.
Dr. David,
yes,
you have a minute to round up.
Okay, thank you, sir. So, complications of the procedure can include risk of GS, complications including disequilibrium, tinnitus, cranial nerve pulses, CSF leak, meningitis, pneumocephalus. Also, recurrence at the risk of coma and death. Complications may also be related to positioning, including embolism in sitting position and subdural hematoma in sitting position. The neuropathies, compressive neuropathies may also result from positioning, especially in back bend position if the pressure points are not well padded. Follow-up of these patients entails evaluation of hearing and facial nerve functions, monitoring for recurrence. Also, for patients that have recurrence, radiation therapy might be an option. Let us some laboratory experimental drugs have been suggested following some studies done at the certain University of Harvard. Targeted drug therapy using hypo pathway inhibitors and mifepristone, which have been shown to reduce the volume of this tumor. But these are laboratory-based studies and have not been confirmed in humans. By conclusion, vestibular schwannoma management has brought towards a multimodal patient-centered approach, balancing weight and stand, stereotactic radiosurgery, and microsurgery. Focus has shifted from total resection to long-term tumor control with maximum preservation of quality of life, specifically facial nerve and hearing. Recent studies focus on molecular therapies and improved hearing preservation techniques. The retrosigmoid suboccipital approach remains favored among neurosurgeons for microsurgical resection. These are some of our references. Thank
you. Thank you, Dr. David, for the presentation. Okay, we have come to the end of today's presentation. It's now time for questions and answers. You can actually raise your hand if you want to ask a question, or you can send your question through the text box that can be communicated to the presenters. Thank you very much. So if you want to ask a question, you can raise your hand. We want to also recognize the presence of our NANS president, Professor Femi. You're welcome, sir. Question and answers. If you have questions, you can raise your hand, or you can send your question through the box.
Yeah, Mr. Moderator, I think someone is raising up his hand, Junior Ome, somebody like that.
Okay, even I cannot see the list. Okay, you can go ahead with the question. So Dr. David and Awoyemi, just get ready to copy down the questions so that you answer them at the end of the questions.
Good evening, Dr. David and the organizers of this webinar. It is quite interesting. I have an observation. Most of the slide you showed, I don't know the reason why you are not using pointers. please, maybe for subsequent webinars. Then you didn't, maybe because of the time constraint, you didn't tell us about prognosis. So I want to know, like the case presentation that warranted this webinar. Maybe I wasn't following because there was a time we were actually not hearing anything and nothing was showing on the screen. How is this patient? I mean, the case presentation. The first question is the prognosis of this case, this vestibular schwannoma, and then the case that was presented, the 47 years old, if I'm not mistaken. How is the patient doing presently? Is the patient alive? The follow up and all that. Thank you very much.
Other questions? Okay, there's a comment in the box. I don't know. The name comes as T. He said, in your epidemiology slide, you said 80% of intracranial tumors are vestibular schwannomas. My thought is that gliomas are the most common. How come the high percentage in the epidemiology? Anyway, I think you might need to clarify that because I don't think that was what was said. Okay. Other questions? Suleiman, you can go ahead with your question. Suleiman Abdullahi.
I just moved my hand.
Okay, I thought I saw your hand raised. Okay, is it that we actually, the thing was not clear or it was too clear that there are no areas to clarify? Okay, another question from the same person, Mr. T or Dr. T. For the approach you mentioned, 3, in which situation is the combined approach used? That's another question. So, Dr. David and Dr. William, I hope you're taking notes.
Yes, sir.
Okay. You might need to start answering since others are not coming up.
This is Dr. Abayomi Samuel speaking.
Okay.
Thank you for the question and comments. The patient that we presented for the case presentation, the woman is well, apparently well. She's alive and she's alive. Just that she has progressive hearing loss on the right side and unsteady gait. So, but she's alive. And then for the issue of percentage of intracranial tumors, I think
Hello, Dr. David or Dr. William? It's like we have lost them. Dr. David. Hello, Dr. David.
Mr. Moderator, maybe Dr. David can answer the questions pertaining to Dr. Awoyomi and also his own question so that we can progress.
Yes, it's like two of them are not reachable now.
Oh, I see.
Maybe they are still using the same network.
So I think we can progress to other aspect of the webinar so that we don't waste much time.
Yeah, I think so, since the questions are not much. But let me clarify to the first question. Actually, he didn't say anything about the prognosis of the patient because they are yet to operate on the patient. They said the ones they operated before, they couldn't have access to the information. I don't know what that means, but that's what they said. But this present case, they are yet to operate. All right. Then I think the person that asked questions on the epidemiology, and he didn't say 80% of intracranial tumors. He said 80% of CP angle tumor. He made a mistake actually, but he meant 80% of CP angle tumor, which constitutes 8% of intracranial tumors. Thank you. Okay, I think with that, we'll go to the next stage. It's time for us to introduce our faculties today. I want to introduce our first faculty. May I introduce Mr. Andrew F. Alalade. He is the current General Secretary of the Medical Association of Nigerians across Great Britain. He's a consultant neurosurgeon at Lancashire Teaching Hospital, NHS Foundation Trust. He's an honorary senior clinical lecturer and undergraduate education lead at Royal Preston Hospital for University of Lancashire. He completed his neurosurgical training in the London North Thames rotation and subsequently undertook the Vaso HCA International Foundation Traveling Fellowship at Wells Cornell Medical College, USA. He later completed Advanced Specialty Fellowship at Princess Alexander.
Matthew, don't worry about it. Thanks for the introduction. I'm just worried about time because I might have to leave soon. So I want us to kind of quickly just do it so that I can leave. I'm at the airport and they're gonna call my flight soon. Yeah.
Okay, sir. Thank you, sir.
No
so
problem.
The next faculty is Professor James Balogun, who also is a professor of neurosurgery at UCH. So for want of time, we'll go straight to the faculty, starting with Dr. Alalade for his own comments and contribution. Thank you, sir.
Yeah, I think it was a brilliant presentation. It was really good. They touched on a lot of things. I know if we probably gave them time, they would have touched on a lot more stuff. I wanted to highlight, I was jotting while he was talking, so I wanted to highlight a few things. Vestibular schwannoma used to be thought to arise from the superior vestibular nerve previously. Over the last 10 years or so, they're finding out that it's more from the inferior vestibular nerve. He mentioned something about the fact that we're MRIing a lot of patients now. We're picking up a lot of vestibular schwannomas, and that's absolutely true. There was a paper in '95 that talked about 15% of patients with asymmetrical hearing loss would have a vestibular schwannoma if they are investigated. So nowadays, most of my patients typically will come in through the ENT referral pathway, because the ENT team would see a patient with deafness, asymmetrical, worse in one ear. Of course, as we get older, we tend to most people tend to get deaf anyway. But usually, like you said, pretty much between ages 50 and 60, if you have asymmetrical hearing loss, then there's always a chance it could be a vestibular schwannoma. And at least I have seen 3 or 4 patients in the last 2 years who have had CTs for different reasons, and large vestibular schwannomas were completely missed. So the MRI remains the gold standard, and it always helps to look at the posterior fossa, even on CTs, because sometimes you're looking, some of these patients were initially scanned for trauma or brain bleeds, and nobody picked up the vestibular schwannoma, and they were large ones as well. So it's always good to look at the posterior fossa, because you might see something that you do not expect. For anatomy in the inferior acoustic meatus, it's always important to remember that there is another nerve in there next to the facial nerve called the nervus intermedius, which is also known as the nerve of Risberg, which is a sensory and parasympathetic nerve. So it goes with 7 and 8. You know that diagram that David showed, 7 up, coke down. So on the side where there's the facial nerve, there's facial nerve superiorly. So that's the 7 up, and then there's the cochlear nerve inferiorly. And usually when you're dissecting, you can see the nerves as well. You would see that the cochlear nerve and the facial nerve, they tend to have different colors. You can pretty much see the vestibular on one side, the facial on one side. The facial will always be slightly whiter than the vestibular nerve. Hearing, all treatment modalities tend to affect hearing. If you're able to keep hearing during surgery, then it's actually the one that has the slowest deterioration of hearing, if you're able to keep it during surgery, especially with ABR monitoring. But no matter what you do with these tumors, whether it's wait and watch, or you monitor them radiologically, or you treat them with radiotherapy, or you treat them with surgery, all these patients, their hearing tends to go anyway in the long term. In the short term, radiotherapy seems to be the best because it doesn't cause a quick deterioration. But if you're able to keep hearing following a resection of a vestibular schwannoma, then the deterioration is slowest with following surgical excision. The problem is that when you look at the mean, a lot of patients lose hearing during surgery anyway. He talked about the 2 procedures, retrosig and translab. They used to use medial fossa approaches for the small lesions previously, if it's less than 10 centimeter, but those were the really tiny ones. And that's pretty much something led by the North American surgeons. But over time, because they found out that a lot of these tumors do not necessarily grow, middle fossa approach is pretty much becoming less of a treatment modality for vestibular schwannomas. Translab is used, and you rightly said it's used for patients who they've completely lost hearing, because you're going to destroy pretty much the hearing apparatus. You're coming up pretty much through the temporal bone, opening up the semicircular canals, and you want to land on the facial nerve, directly on the facial nerve, so that you can save the facial nerve. A lot of these patients can present with hydrocephalus. It doesn't necessarily have to be obstructive hydrocephalus. There's some patients that present with something very similar to Freund syndrome, where there is xanthochromia within the CSF. So you find out that even without obstruction, there's proteinaceous substances secreted into the CSF, and patients have hydrocephalus. David, you said something very interesting when you talked about the blood supply of vestibular schwannoma. I don't know whether it was you or Awo Yomi, about the internal auditory artery. Do you know what the other name of the internal auditory artery is?
Then this one, keep this one too. Might need it.
Let's mute MO11. David or Awoyemi, are you there?
Yes, sir. We are here. We are using a different device. So the other name for internal auditory artery is the labyrinthine artery, sir.
Okay, and it comes off what artery?
Oh, it's a branch of the anterior inferior cerebellar artery, sir.
Yes, yes. And that's why even though embolization is becoming popular for a lot of tumors, nobody will suggest, thank you, nobody will suggest embolizing the vestibular schwannoma because, embolization would pretty much block off the ICA, and then you make the patient deaf anyway. So it's never really been muted as an option. Risk factors, nobody's really sure what the risk factors are at the moment. You mentioned the hippo pathway inhibitors that are becoming popular, like bevacizumab for NF2 tumors, but they are still at experimental stage, just like you said. But hopefully, maybe over the next couple of years, we'll get more, with the CT head, so there's one skill I've started to use from the professor in my department. Before every surgery, he would actually go through the scans again, regardless of, pretty much skull-based tumors with the radiologists. And the truth is that even though we really know how to interpret scans, sometimes the radiologist would always give a new perspective. Of course, it's usually it's usually better if it's a neuroradiologist. So with the CT, we tend to look for, especially on the coronal slices, you want to look for the high riding jugular bulb, because if you're doing a retrosig approach and you're drilling the porous, if it is high riding, you will only need to drill a little bit bone and you will be hitting the sigmoid sinus under the bone. So it's always and nobody wants that during surgery. So that's the main reason why we do CTs for what they call it, pre-op for vestibular schwannomas, especially when you're doing retrosig. And then for the MRI scan, sometimes you want to see where your nerves are. You can do if there's a cis sequence to see 7, 8, just to give you an inkling of where they are. You can also look for other things like the pneumatized sinuses, mastoid air cells, and whether the transverse sigmoid sinuses are dominant on the side you're operating on. For radiotherapy, stereotactic is usually one dose. Fractionated is usually repeated doses over about 5-6 weeks. And most of the radiation people do not like the vestibular schwannoma to be touching on the brainstem. So sometimes if it's touching on the brainstem, they might tell you that, they don't want to give radiotherapy, just so that it doesn't affect the brainstem, and they'll want you to resect it at least off the brainstem. These cases, we all know that a big complication is facial nerve palsy. And facial nerve palsy is, even from the largest centers, they notice post-oping even up to 40% sometimes. A lot of them will recover if they are low-grade House-Brackman scores. A lot of them recover, but it's always within 6 months. But it's always good to also liaise with like the plastics team. Or, now we're beginning to have people who have expertise in facial palsy plastics. So they have ways of cosmesis even after surgery. So sometimes they can do either a nerve anastomosis, hypoglossal facial, or sometimes they do what they call a segmental kind of repair, where they put an upper lid weights, leads in the upper lids, weights in the upper lid, and then they sometimes inject Botox into the masseter and have a segmental transfer. So it's done in a 3-stage process. So sometimes if I have a patient who has bad facial nerve palsy, then I would typically get them to the facial palsy team under plastics. pretty much for rehab and a repair. Complications, you rightly mentioned them. You have to position properly and make sure there is adequate padding. I think as a registrar, I remember a patient who had a brachial neuropathy. And that's one thing that not many people talk about, because when you're positioning a patient for in a park bench position, if you do not put proper axillary fold padding, then you can injure the brachial plexus. So it's important to make sure they're well positioned. I think that's pretty much what I can remember now of the presentation. And I'll hand over to Professor Balogun for his inputs. Thank you.
Well, yeah, so I think we can round up very soon. I wouldn't want to repeat some of the things that Dr. Alalade has mentioned, and I'm glad he was able to make it because I really wanted him to add his voice to this discussion. Actually, also wanted Professor Bankole to be around to kind of add his voice, because I also know that he's been exposed to some of the approaches that we're discussing here. I think in summary for me, vestibular schwannomas, actually, they kind of like that set of tumor that have varied management options. And some of those management options are actually very valid, from observation all the way to surgical approaches and radiotherapy. And I think this is one tumor where understanding not just the pathology of the tumor, but also understanding all of the clinical radiological features would help you to really choose the appropriate treatment plan. I like the last part where Dr. Alalade talked about facial nerve injuries, right? So the facial nerve, it really is just one nerve out of that tumor. It's not really included in this tumor, but then is this one nerve that can actually mar everything that you have done as a surgeon, because you really didn't operate on the facial nerve, you remove the tumor, and now the patient's got a morbidity that cannot be hidden. Like he's got a Hauser-Brackmann 4-5. Like he said, you got to fix it. And sometimes we've seen where people monitor facial nerve up until the last minute, like you hear it, and then just at the end, you cannot hear it anymore, and that's it. Like, so it's really something that puts the surgeon on the edge. So really important to pay attention to it. But let me start with the fact that whilst this is more common in HIC country, there has always been debates about the epidemiology of vestibular schwannomas in our part. And I remember that Professor Hoag Williams group from Enugu had actually at some point actually written a paper to say that this is really scarce. And for most people in their practice here, you probably don't see them as often as you would probably see even a meningioma in that space or an epidermoid cyst in the CPA angle. The thing I really also want residents particularly to take away, and particularly young faculty here, is the fact that I wish that the presenters actually pay attention to the anatomy, really, because the anatomy of the petrous apex and the anatomy really of the CPA is the real deal here, because all of the approaches we're talking about, the translab approach, the transcochlear approach, whatever approach from the middle fossa, and then you go. And like most score-based guys will summarize, whether you're looking up or you're looking down. So if you're coming from the middle fossa through that, you're looking down. If you're going from posteriorly, you're looking up. All of that, yeah, I think is anatomy. And I wish that some of the things Dr. Alalade said, some of the things I think Dr. Edet said in terms of CT, anatomical delineation for this class of tumors, actually comes from understanding the basic anatomy around that area. And I like the way he took him up on the labyrinthine artery. Okay, so obviously, someone like Albert Rothorn had always made that emphasis, particularly with respect to that artery coming from ICA and all that. So it's important that residents go back after this presentation to really look at the anatomy of the petrous apex from anterior to posterior, and all of what can happen there, because even the pre-sigmoid approach and the retro-sig approach really is dependent on understanding the anatomy and the CPA angle anatomy. Now, the person who also talked about the anatomy of the CPA angle, I think just for the basis of residents in particular, it's not just the fact that it contains cranial nerve 5, 7, and 8. Actually depends on what compartments of it you're looking at. And obviously, when you're working from the CPA, from the retro-sig approach, one of the things I always tell residents is the fact that draining CSF is your greatest friend. So some of these complications of cerebellar retraction and all that, if you're just very, very patient with getting in, get as much CSF out, you would be amazed at what anatomy you can actually see beyond even eighth nerve. You probably, if you look down properly, and well, depending on how much you go down with your bony removal, you actually can see as much as 9, 10, 11, 12. So again, I think it's important that if you understand the anatomy and the compartmentalization of that CPA angle, which is why most people will say that retro-sig approach is actually the workhorse of the posterior fossa. You understand it, you probably would be able to do as much approaches and adapt the approaches to it. And again, I think it's important to also stress that tumor size, just as we know, tumor size, tumor location, and particularly what clinical presentations you have from the patient are very key, or they're the keys to what decisions you make in terms of how you treat this patient. And just to throw it in, I actually like that slide that talked about, I don't know, small, medium, large, and giant. And I was laughing because I got a text from Dr. Alaladi about pituitary tumors, because if you juxtapose it, we talk large, 3 centimeter, 4 centimeter, it's always almost the same. But that nebulous between 1 cm and 3 cm, nobody really puts a tag on it. And that you guys put a medium tag on it, it's kind of tricky, but again, I think it's just paying attention to some of the details. I think I would really just stop here. The other thing is, I don't know what thoughts Dr. Alalade has about cystic vestibular schwannomas, because some of the other guys also talk about the fact that, you see, when you see a cystic tumor, you think, okay, you just kind of bump into it, you do everything. Sometimes
I actually wrote it down and I forgot, so I was waiting. So great, man, well done.
All right, so some of it can actually be more even aggressive than what you talk about the solid tumor. So pay attention to some of those details. And I like also his thoughts about the fact that you think these tumors can be picked always by MRI, sometimes it just depends on what you're paying attention to. So again, I would just round up. I think it's about 20 minutes to 6, and so people have been here for close to 1 hour, 40 minutes. But I would like to hear Professor Bankole probably chipping in 1 or 2 words before we round up. Okay, Professor Bankole, sir.
Professor James, why are you dragging me out?
Why has he
Anyway,
called you out?
yeah. You know, the YNF president had alerted me earlier. Anyway, thank you everyone for the presentation, and thank you especially to the faculty for their very insightful comments. Realistically, probably all that needs to be said has been said. In our environment, we hardly use the trans-lab approach for various reasons. Our ANT folks are not comfortable with it. At least in my conversations with them, that was what they made me realize. And also, I know that in some places, like in India, the neurosurgeons themselves may do the approach, even the trans-lab approach themselves completely. But when my experience really I found it takes a fairly long time to do, just even the approach itself relative to a retro-sig. And I remember when I was exposed to it in Salford, and I just told them that, man, I'm going to watch this, I'm going to try and understand it, but realistically, I can't see myself doing this when I get back home because I just don't have the operating time to play with. You get one shot at stuff, and if you take the whole day on half the case, then you're not going to get around to doing much. But like you noted, the benefit of the translab is to try and improve your facial nerve sparing rates. Well, I don't know if fortunately is the right word, but many of the patients that we see are already, hearing loss and already have some measure of facial nerve weakness or the other. So the drive for that is not so much. I think that with proper monitoring and with care, using the retro-seq, then you can at least preserve reasonable facial nerve function. It doesn't mean you get it all, but it is reasonable. The question of prognosis, I think the truth of the matter is it's a benign tumor. Prognosis-wise, patients will rarely die from it, but they will lose their hearing. And if it gets really, really big, then it can become a problem as well. So somebody was asking about prognosis. We do not see them that often. That's just the truth. Even now, we have MRIs picking up empty cellular syndromes and stuff that people send to you. We still don't see vestibular schwannomas as often as the literature would suggest we should. So possibly it's something we can look at nationally and get a sense of what's going on. I don't know. Do you see a lot of Black people with vestibular schwannomas in the UK? Yeah, so maybe it's something in the genes that we need to think about and look about. Anyway, so thank you, everyone. I think it's been a good time of learning, and wish you guys a great weekend ahead.
Thank you, Professor Bankole, our immediate past president of NANS. We are grateful. Thank you for your contribution. We want to also thank our faculties for their contribution. Professor James, we are grateful that you're able to make it. Thank you for the insightful thoughts and all that you have reviewed to us in this program. Thank you, Dr. Lalade, for making our time despite your journey to be with us and to make such contributions. We have learned a lot and we are grateful for your time. We will go to recognize some other senior colleagues who are around and then others that also want to make contributions in this presentation. We want to recognize the presence of our chair, YNF chair, Dr. Olumoyewapara. You're welcome. We also want to recognize the presence of the co-chair, Dr. Femi, and also, I think, the secretary, Dr. Antokuba. You people are welcome. Thank you very much. I don't know whether there's any other senior colleague around. We want to welcome all of you. And then if you have any contribution or any comment to make, we can briefly do that before we close for the day. Thank you very much. Well, in the absence of further contribution, I want to hand over back to the organizers. I want to thank them for the privilege to moderate this program today. I want to thank everybody that participated, and I thank the contributors for enriching our knowledge. Thank you very much.
All right, thank you, everyone. Have a lovely evening. Thank you.